Good morning everyone. My name is Chandrakant Lakkamwad, roll number 16, and today me and my friends from roll number 16 to 30 are going to present talk seminar on osteology of lower limb. So we have learned all the anatomy of lower limb, but today we are going to learn in an interesting way. What is that? So we are going to present you a case that is clinical. So about it we will first learn what is the anatomical aspect and then we will see the clinical aspect. So let us start. Today I am going to, my topic is that I am going to present a case that is clinical and my colleagues will further discuss it with you. So as I introduced, my name is Chandrakant and roll number 16. So we will see the clinical case. So there is a patient, her name is Shubhada. She is a 70-year-old woman, came to an orthopedic OPD. She has severe pain in her left hip and knee joint. She had history of falling in bathroom, falling in bathroom, and she has no another history of any accident, injury or trauma. On examination, she was lying supinely and the limb was shortened and externally rotated. So she had complaint of extreme pain in the left hip. So the doctor ordered for an X-ray of hip and so as you can see he ordered for an X-ray and as you can see that this is normal. The white line which is shown here, this is a normal. So in the left side, as you can see, this is the left hip X-ray. So there is a break in a shenton line. This detail about the shenton line will be discussed by my friends. So this is all about the case, and next anatomy and other aspect will be discussed by my friends. Thank you. I call upon Tejasri for the next topic.
Good morning everybody. This is Tejasri, roll number 18. Today I feel honored to explain the topic called anatomy of femur.
Mic.
Okay. So femur is not just the longest and strongest bone of the body, but it also helps in a posture, weight bearing and function. So first of all I start with the anatomical position and side determination of femur. So there are 2-3 factors for anatomical position. The head is directed medially upward and slightly forward, from which we can determine the lateral and medial side. And in shaft there is linea aspera is present, and in lower end there is the intercondylar fossa is present, from which we can determine the anterior and posterior side. So from which obviously this is right side of femur. And now we turn to features. So from study point of view, there are 3 parts of femur, that is upper end, shaft and lower end. In the upper end there is a head is present, and head is rounded and it is attached to acetabulum of hip bone to form a hip joint. And in the center there is a fovea capitalis is present, which is a deep impression of it. And there is a neck is present. Neck have 2 borders and 2 surfaces. In upper border we have a greater trochanter, and in lower border we have a lesser trochanter. And the anterior surface we have a intratrochanteric line which is completely intracapsular. And the posterior surface we have a intratrochanteric crest which medial half only is intracapsular. And at the center of the intratrochanteric crest there is a chondric tubercle is present, we can see here. And next turn of shaft. So shaft we have a 5 borders and 5 surfaces and 3 borders. They are anterior border, lateral border, and we have a 5 surfaces: anterior, medial and lateral, and upper posterior and lower posterior. And we have 3 borders: lateral, medial and posterior. Posterior border is also known as the linea aspera, which is formed by the medial lip and lateral lip, which is a continuation of the intertrochanteric crest and greater trochanter respectively, and which turn at lower end they are continued to the medial and lateral supracondylar lines. And in the lower end, last we have a medial epicondyle, lateral epicondyle, and intercondylar fossa. And in the medial epicondyle, there is a quadrate tubercle is present. So this is all about the femur anatomy. The next topic is explained by my colleague Saloni. Thank you for your patient listening.
Good morning everyone. This is Saloni Dikuna, roll number 17. Guys, Tejas discussed about the anatomy of femur with you guys. Also, in our daily life, we run, we sit, we do numerous activities in which our lower limb is used. But have you ever thought how these actions are possible? It is possible due to presence of many muscle attachment, especially over the hip and the knee joint. So hello, I am going to present you about the muscle attached to the femur bone. Once again, my name is Saloni Dikuna, roll number 17. For the better understanding, we can divide the muscle attached to the femur into three parts. Firstly, muscle attached to the upper end. Second, muscle attached to the shaft. And thirdly is the muscle attached on the lower end. Talking about the upper end is been subdivided. Talking about the head of the femur, we have attachment of the ligament of teres femoris in the fovea. Talking about the greater trochanter, we also have an attachment of the we have attachment of the obturator internus and two gemelli. Obturator externus is attached in the intertrochanteric fossa. Also, we have the attachment of the upper and lower bands of the iliofemoral ligament. Now, as we move forward, we have the attachment of gluteus minimus. On the intertrochanteric line, we have the highest fibers of vastus lateralis above, followed by the highest fibers of vastus intermedius below. So this is all about the head of the femur where numerous muscles are being attached. Talking about the muscle attached on the anterior surface shaft of the femur, the whole shaft, nearly the 3/4 anterior surface, is covered by the muscle that is known as vastus intermedius. Below vastus intermedius, there is attachment of articularis genu. Lesser 5 cm of the femur on the anterior surface contains the suprapatellar bursa, which is useful in the knee joint. As we move forward, we will see about the attachment on the posterior aspect of the shaft of the femur. We have the posterior border, none other than the linea aspera. Talking about the muscle attached to the linea aspera from the medial to the lateral side, firstly, there is attachment of vastus medius, followed by adductor longus, adductor brevis, adductor magnus, and lastly that is vastus lateralis. On the lower end of the femur, there is a medial epicondyle, medial condyle, lateral epicondyle, and lateral condyle. Talking about the medial epicondyle, there is attachment of the tibial collateral ligament. Now this tibial collateral ligament is helpful in the knee joint. Same, on the lateral epicondyle, we have attachment of the fibular collateral ligament. On the lower aspect of the shaft of the femur, on the lateral side, we also have, there is attachment of the plantaris muscle. Lateral condyle gives an attachment to the lateral head of the gastrocnemius, whereas the medial head of the condyle gives the attachment of the medial head of the gastrocnemius. As we move forward, the muscle attached on the lower end of the femur, when we see about this part, there is attachment of the popliteus muscle on the lateral aspect at the lower end on the posterior shaft of the femur. Also, there is, as I told about the lateral head of gastrocnemius, also there is attachment of fibular collateral ligament. Now, talking about, there is present of anterior cruciate ligament and posterior cruciate ligament. Now, this anterior cruciate ligament, which is present on the lower end on the posterior aspect of the femur, it is taut during the extension. What does this help in? It helps in hyperextension of the knee joint. Also, now we have the posterior cruciate ligament. This posterior cruciate ligament is taut during the flexion of the knee joint, and this thus helps in hyperflexion of the knee joint. So as we discussed about the muscle attached to the femur on the head, shaft and the lower end, any damage or paralysis of this muscle would bring difficulties in the movements carried out by this particular muscle. Now we will be studying about the normal anatomy of the hip joint. For this, I would like to call Dhruti. Thank you.
Good morning to one and all present here. Today, I, Dhruti Bhale, roll number 19, is going to explain you about the most important and strongest joint of our body, that is the hip joint, which is necessary for weight bearing. First, we will see what type is it. It is a ball and socket variety of synovial joint and it is multi-axial. The hip joint is designed in such a way that it gives stability. So in hip joint, mobility is compromised for stability. Coming to the articulating surfaces, the articulating surfaces can be divided into two, that is superomedial and inferolateral. As you can see in this picture, the superomedial surface consists of lunate surface, acetabular notch and a transverse ligament. And the inferolateral surface is made by the head of femur, which is covered entirely by the hyaline cartilage except at the fovea. Next, let's learn about the capsule and ligaments. The capsule superiorly extends from the acetabulum, acetabular labrum and transverse acetabular ligament till the intertrochanteric line and on the anterior side and posteriorly till the intertrochanteric crest. There are three ligaments joining the pelvic bone to the femur. First is iliofemoral ligament. It is the strongest ligament of our body, Y-shaped, and it has an opening to a bursa which is deep to psoas major. So in any type of infection to the hip joint, example osteoarthritis or rheumatoid arthritis, the infection can spread from this ligament. Next is the pubofemoral ligament, as you can see in this picture, present posteriorly. Pubofemoral ligament and ischiofemoral ligament. So this is the summary: capsule plus three ligaments joining the hip bone to the femur and three ligaments restricted to acetabulum, that is the acetabular labrum, ligament of head of femur and transverse ligament. Thank you. Now I would like to call upon Disha to continue further. Iliofemoral ligament from the anterior inferior iliac spine till the intertrochanteric line.
Good morning to one and all present here. Myself Disha Mandavia, roll number 21, and I'll be presenting about relations of hip joint and the bursas related to it. So first of all, why it is important to understand about the relation. So it is useful in clinical and surgical practices for applying the injections, or also it is useful in understanding the referred pain. So anteriorly there is the presence of straight head of rectus femoris, tendon of iliopsoas, femoral nerve, femoral artery, femoral vein in the femoral sheath. Also, there is the presence of synovial bursa that is present between the hip joint and the tendon of iliopsoas muscle. Next, posteriorly, there is the presence of gluteus maximus muscle, piriformis, obturator internus with the two gemini, quadratus femoris and bicep femoris. There is the presence of sciatic nerve as well as the superior and inferior gluteal vessels. Looking at the superior relation, there is the presence of the gluteus maximus, gluteus minimus and the gluteus medius muscle, as well as the reflected head of rectus femoris. Inferiorly, there is the presence of adductor muscles, that are the adductor magnus, adductor longus and adductor brevis. Also, obturator externus is present. We can understand all these by this simple flowchart. Now, moving forward, we'll understand about bursas. What are bursas? Bursas are the thin synovial fluid-filled linings, and their main action is lubrication. They reduce the friction between the bones as well as the tissues. So, the first one is called trochanteric bursa. Trochanteric bursa is present between the greater trochanter and the gluteus maximus muscle. Next is the gluteofemoral bursa. It is present between the iliotibial tract and vastus lateralis. Next is the ischial bursa, that is present between the ischial tuberosity and the gluteus maximus muscle. Ischial bursa is also known as the weaver's bottom, and it can get inflamed while we sit on a long surface for a longer time. Next is the iliopsoas bursa, which is this purple color one, and it is present between the tendon of iliopsoas and the anterior hip cavity. So now, that was all for it. Now we'll understand about the blood supply, nerve supply and the movements by Digvijay. Thank you so much.
Greetings to one and all. I am Digvijay Gaikwad, and today I will be presenting the blood supply, nerve supply and the movements of the hip joint. The blood supply of the hip joint. The hip joint is supplied by the obturator artery. The acetabular branches of the obturator artery supply the small part of the head of femur and the region near the fovea capitis. The medial and lateral circumflex femoral arteries. The medial and lateral circumflex femoral arteries are the branches of profunda femoris artery, which form an arterial circle around the neck of the femur and supply the major part of the head of the femur. There is a clinical importance of these medial and lateral circumflex femoral arteries. That is, they give the retinacular arteries, which are the branches of the medial and lateral circumflex femoral arteries. If they are damaged in case of the fracture of the neck of femur, the major blood supply to the neck of the femur is lost, and there is a delayed healing in that case, and it leads to avascular necrosis. And it is also supplied with superior gluteal artery and inferior gluteal artery. The nerve supply of hip joint. Hip joint is supplied by the following nerves. The femoral nerve, anteriorly the femoral nerve, we are nerve to rectus femoris and the obturator nerve. Posteriorly the nerve to caudatus femoris, and the superiorly by the superior gluteal nerve. And this is by the Hilton's law, that the nerve supplied to the muscles also supply the hip joint, the joint. The movements of the hip joint. Movements of the hip joint are flexion and extension in the flexion and extension, external rotation, internal rotation, and abduction and adduction. The flexion and extension is in the transverse axis. The flexion and extension is in the muscles involved in the movement of hip joint. The flexion is the chief muscles involved in flexion are iliacus and psoas major. The chief muscles in extension are gluteus maximus and hamstrings. In adduction are adductor longus, adductor brevis, and adductor magnus. In abduction are gluteus medius and gluteus minimus. In medial rotation are anterior fibers of gluteus medius and minimus and tensor fasciae lata. And in lateral rotation are obturator internus with two gemini, caudatus femoris and obturator externus. The range of motion of flexion is 110 to 120 degree, of extension is 15 degrees, of adduction is 30 degrees, of abduction is 50 degrees, of medial rotation is 25 degrees, and of lateral rotation is 60 degrees. Thank you, and the next speaker will be Vedant Doshi.
Good morning everyone. Today I will be talking on clinical examination of hip joint. So hip joint is a major joint which carries the load of the body. Any pathology of the hip joint will affect daily walking and daily activities. So we begin the clinical examination by history taking. In history taking, we include points such as pain, its site, radiation and relation to the movement. Then we look for a history of trauma, past accidents and any surgical interventions. Then we move on to general examination. General examination is done to rule out systemic causes. We look for scar, swelling, then we look for any inflammation and overall the length of the leg. Then we move on to the gait. So the simplest definition of gait is mode of walking. Normal gait is rhythmical, bipedal and biphasic, in which the lumbar spine, hip and legs move in unison. Limping is the most common abnormality the patient presents with, which may be antalgic. Then we move on to inspection. In inspection, we look for the limb length and we also look for any other abnormalities, posture deformities. Palpation. In palpation, we look for bony prominence such as greater trochanter, and we also look for any edema and any edema such as pitting edema. Then movements. Both active and passive movements are assessed. The patient may be unable to perform straight legs. Any restriction to the movement indicates pathology of the hip joint. Measurement. We measure the apparent and the real length of the limb. We also measure the calf girth and thigh girth to assess any muscle wasting. After that, we move on to the most common clinical features that a patient may present in the OPD. The patient may present with pain, swelling, loss of function, limp and leg length discrepancy. Then the key examination findings. On inspection, the affected leg is typically shortened, externally rotated and abducted. Active movement, the patient is unable to perform straight leg raises. Rotation, both external and internal rotation is severe. Both external and internal rotation causes severe pain to the patient, and flexion and abduction is severely limited. To conclude, systemic clinical examination of the hip joint, starting from the gait and movements to special tests, is essential for accurate diagnosis and management. Thank you. Now I call upon my colleague to further explain the clinical examination of hip joint.
Namaste everyone, myself Drishna Chauhan, roll number 23. I'm going to talk about the investigations of hip joint. The most important investigation is the radiological investigation, where we take the X-ray of pelvis of both hips in AP view, confirming the fractured neck of femur and the displacement. In the X-ray, we can see the Shanton line, the normal Shanton line, which runs along the inferior border of the superior pubic ramus and the medial edge of the femoral neck. The broken Shanton line here indicates the loss of normal hip alignment, while the shoemaker line, which passes on or above the umbilicus, is here displaced and is below the umbilicus, suggesting limb shortening and displacement. Third, this X-ray confirms the fracture of the neck of femur. Although laboratory investigations are not used for diagnosing the femur, they are important for the preoperative evaluation. A complete CBC is done to detect anemia and baseline hemoglobin, as blood loss due to fracture-related hematoma may occur. Blood grouping and cross-matching is required because the surgical management of hip joint may result in perioperative blood loss. A coagulation profile is done to assess bleeding risk, especially in elderly, because they might be on anticoagulant therapy. RFTs and electrolytes are done to ensure safe anesthesia and surgery. Blood sugar levels are assessed to screen for diabetes and the surgical risks related to them. Since fracture in elders is a fragility fracture, bone metabolism tests are done to screen for osteoporosis. These include the serum alkaline phosphatase, serum calcium and phosphate, and vitamin D levels. To conclude, the major investigation is the radiological investigation of X-ray of pelvis with both hips to detect the femoral fracture, while laboratory assessments are required for surgical assessments and care. Thank you.
Good morning everyone. My name is Anuj Fulsek. My roll number is 24. Today my topic is fracture of neck of femur. There, fracture of neck of femur is categorized into several key classification systems based on various bases. So, there are generally 5 types of classifications, in which I am going to discuss first 2 types. That is, first is this classification system is very essential in clinical practices as it is important in surgical treatment and various complications like avascular necrosis or non-union. So first type is the guidance classification. There are generally 4 types of guidance classification: type 1, type 2, type 3, and type 4. We generally remember it by remembering that the type 1 is incomplete and other types are complete, whether the first 2 types are relatively stable than the next 2 types. And talking about displacement, there is a valgus impacted displacement in type 1, and there is a no displacement in type 2. There is a partial displacement in type 3, and there is total displacement in type 4. The basis of guidance classification is the degree of displacement. So next type is a Powell's classification. The basis of Powell's classification is biomechanical. We generally measure the angle between the horizontal plane and the fracture line. Greater the angle, greater the shearing stress, and there is a high risk of non-union if angle is more. There are generally 3 types, as you see. Type 1, in type 1 there is angle less than 30 degree between horizontal plane and fracture line. It is a more horizontal and it is stable fracture. There is a high risk, there is high chances of union in type 1. And there is type 2, in which the angle is 30 degree to 50 degree and it is a moderate obliquity. Type 3 is the angle is greater than 50 degree, it is vertical and high shearing force, and it is relatively unstable. Thank you.
Hello everyone, I am Srusti Garad, roll number 25. I am going to continue classification of fracture of neck of femur. Our third classification is anatomical classification. It is based on anatomical location of the fracture. The first type is subcapital. The fracture is just below the head of the femur. It is the common site of the fracture. Second is transcervical. The fracture is at the mid portion of the femoral neck. And third is base cervical, that is basal. The fracture is at the base of the femoral neck. Our next classification is AO or OTA classification. It is basically alphanumerical coding given to the type of the fracture. A fracture of neck of femur is coded as 31B. So 31B1 is subcapital, 31B2 is transcervical, and 31B3 is base cervical fracture of neck of femur. Next classification is based on etiology, that is based on cause of the fracture. First is stress fracture. It is due to repetitive mechanical stress. It is generally a small hairline fracture, especially seen in athletes due to their high energy activities, or in individuals having metabolic bone disease. Second is osteoporotic fracture, seen in bones weakened due to osteoporosis, and it is generally seen in postmenopausal women or in elderly persons. Third is traumatic fracture. It is seen due to significant external force, generally in road traffic accident or fall from height. Thank you. I would like to call Sandesh for next subtopic.
सेमिनार चल रहा है, बात कर रहे हो.
Good morning, respected teachers and my dear friends. Myself, Gatwar Sandesh, roll number 26. Today I am going to present seminar on anatomical basis of fracture in femur.
वरती पकड़.
First, the femoral neck is long and narrow. Femoral neck is long and narrow that connects the head of femur and shaft. Head of femur and shaft. Because of its long length and narrow diameter, it acts as a weak point between head and shaft. As the age increases, there is relative thinning makes it prone to fracture. Fracture leads to loss of medial rotation due to paralysis of gluteus medius and minimus. While the spasm of lateral rotation, while the spasm of lateral rotator muscles causes the external rotation of limb due to the lateral rotator muscles, which are piriformis obturator, gemelli, correctus femoris, and gluteus maximus. The anatomical basis of limb shortening. Limb shortening occurs due to head of femur remains in the acetabulum, while the head of shaft is pulled upward because of strong thigh muscles, which are adductors, hamstrings, and quadriceps, which leads to apparent shortening of the limb. In females after menopause, the estrogen level increases, which causes the osteoporosis, reduce the mass and strength, the thinning of cortical and trabecular bone. In females, smaller neck shaped angle increases stress on femoral neck. Due to these reasons, in females there is high risk of femoral neck fracture. Next is anatomical basis of pain and immobility. Hip joint shares the nerve supply with knee, which are common, which is femoral and obturator, and roots L2 and L4, which causes the pain referred to knee joint, disruption of bony continuity, painful movements plus immobility. The next topic is explained by my friend Gaurav.
Good morning everyone, I am Gaurav, my roll number is 27. Today I will be explaining differential diagnosis of fracture neck of femur. So basically what is the differential diagnosis? It is basically differentiating between conditions having similar symptoms. So if there are two conditions and they have similar symptom, but we need to differentiate between them. So fracture of femur is common injury in the elderly because of osteoporosis that makes the bone weak. So the elderly, they present with hip or groin pain, inability to bear weight, shortening of limb, and external rotation of deformity. And this needs differentiation from conditions which have similar symptoms. So let us look at some traumatic differential diagnosis. Firstly, there is intertrochanteric fracture, which is extracapsular, which immediately differentiates it from fracture neck femur because it is intracapsular type of fracture. In intertrochanteric fracture, more swelling and more bruising is seen, though healing is better in it because the blood flow is not compromised. Then there is a dislocation of hip joint, in which the femoral head is displaced out of acetabulum. Limb position is abnormal and it is associated with severe pain. It usually happens after a major traumatic accident. And then there is fracture shaft of femur. In fracture shaft of femur, deformity is mainly in the thigh region, which differentiates it because in fracture neck of femur, the deformity is mainly in the hip or groin region. Obviously, in fracture shaft of femur, swelling is seen in the thigh region. Then there are some non-traumatic conditions like trochanteric bursitis, osteoarthritis of hip, and avascular necrosis of femoral head, in which pain is gradually seen. Then there is stress fracture of femoral neck, which is mainly in athletes, and the pain increases with increased activities. Then to confirm, diagnosis is based firstly on clinical signs, which of course include shortening and external rotation. Then there is X-ray of pelvis with both hips, and if the X-ray is doubtful, MRI or CT scan is done. And To conclude, differential diagnosis is really important to give proper treatment plan. Thank you. I would like to call Prathamesh for next.
Good morning everyone. My name is Prathamesh Gosne and my roll number is 29. My topic is about treatment of fracture neck of femur. So fracture neck of femur is common orthopedics. Fracture neck of femur is common orthopedic surgery. Occurs mostly in elderly persons due to osteoporosis. It requires early diagnosis and proper treatment for better healing. There are to treat this. There are two types of treatment, that is conservative treatment, which is also called as natural treatment, and other is surgical treatment. Conservative treatment methods are like bed rest, skin traction, analgesics, and gradual physiotherapy. But there are some disadvantages of this treatment, that is non-union occurs, vascular necrosis, bed sores, etc. Since this is the natural method, it takes a greater time than that of surgical method to heal. Other treatment is surgical treatment, in which indications are the displaced fractures, the patient should be young, or if failure of conservative treatment takes place, then surgical treatment can be done, which requires early mobilization. And the types of surgical treatments are internal fixation, hemiarthroplasty, and total hip replacement. In internal fixation method, we use cannulated cancellous screws, dynamic hip screws, multiple pin fixation, as seen in this radiogram. It joins the hip and the neck of femur. The indications for this method are the patient should be young, the fracture should be undisplaced, or the fracture should be recent, that is less than 48 hours. Another method is total hip replacement. In this method, the replacement of both acetabulum and femoral head takes place, which is used in active elderly patients and used when arthritis is present. So, the natural healing method, it is used, surgical method, internal fixation method is used in young patients, while the total hip replacement is mostly used in elderly patients. It also requires post-operative care like physiotherapy, early mobilization, antibiotics, weight-bearing exercises, etc. If this is not taken properly post-operative care, then it will lead to severe complications, which will be later presented by my colleague Vikram. So I would like to invite him to present next talk. Thank you.
Good morning everyone, myself Vikram Gowde, roll number 28. Today's my topic is complication after treatment of fracture neck of femur. In this we see the two major type of treatment is present. First is internal fixation, second is total hip replacement. Now we discuss the complication after internal fixation treatment and after total hip replacement treatment. There are also different types of complication present in internal fixation. In internal fixation, early complication, late complication, biological complication, and mechanical complication are present. After total hip replacement, early complication, late complication, and thromboembolic complication present. Now we discuss complication one by one. In internal fixation, early complication, first is infection at surgical level. After an operation, surgical area get infected. This infection cause problems like swelling, redness, pus, etc. Second is diffuse thrombosis. In diffuse thrombosis, the after treatment blood get thick and forms clot inside deep vein. This condition known as diffuse thrombosis. Third is excessive bleeding. During this treatment, there are high chances to damage blood vessel and there cause excessive bleeding. Fourth is fat embolism. After fracture, the bone marrow releases small fat particles into blood vessels, and these fat particles forms clot inside the blood vessel. And fifth is pulmonary embolism. In this condition, these fat particles blocks lungs arteries and affects the blood flow. Now we discuss the late complication in secondary osteoarthritis. In this, bone arthritis occur due to previous fracture. Next is chronic pain. In pain that continues after fracture is completely healed. Third is joint stiffness. In joint stiffness, joint is there are difficulty in joint movement, and fourth is need for revision surgery. Second surgery done to replace or correct first surgery. Now we discuss mechanical complication. In mechanical complication, first is implant failure. In this condition, implant is not work properly. This condition known as implant failure. Second is screw cutout. In this condition, we use surgical screw. This surgical screw dislocated from its position. And next is backing out of screw. This complication is same as previous complication. The surgical screw loose and dislocated from its position. Fourth is malunion. In this condition, fracture is healed but in abnormal position. And now we discuss the biological complication. In biological complication, non-union fracture. In this condition, joint is does not join back together. Next is delay union. In this joint fracture is healed but takes more time than normal fracture. Next is skull necrosis of femoral head. The death of bone tissue of femoral head due to loss of blood supply. Next is shortening of limb. After treatment, the length of limb get reduced. Now we discuss the complication of total hip replacement. In early complication, hemorrhage and hematoma. Total hip replacement treatment is very complicated treatment. In this treatment, we replace head of femur and also acetabulum. Therefore, the high chances to excessive blood loss. Therefore, the hemorrhage and hematoma can be occur. There are high chances to nerve injury, mainly sciatic and femoral. And third is dislocation. In this dislocation, implant get dislocated after treatment. Next is muscle weakness. The strength of muscle get reduced. Now we discuss the late complication, septic loosening. Implant get dislocated from its position without any infection. This is known as aseptic loosening. Second is prosthesis wear. In this, the gradually damage of artificial joint surface occur. And third is periprosthetic fracture. The new fracture arises around the implant. This condition known as periprosthetic fracture. Now I would like to call my next colleague, Sir Ayush. Thank you.
Hello. Good morning, everyone. My name is Ayush Dinesh Ghatkar, roll number 3030. So, finally, we have come to the end of this seminar, and I am here to summarize this seminar in a nutshell. So, first, we started with a case presentation. A case of a 70-year-old female who had suffered a fall in her home. She had come to the OPD with pain in her left lower limb. On clinical examination, her left lower limb was shortened and it was externally rotated. So, in relation to this case, we then saw the normal anatomy of femur and hip joint. Now, through the general investigations and the initial examination, we suspected that this might be a case of femur neck fracture. So, we saw how the femur neck fractures are classified and what are the bases of different classification systems like the anatomical, Gardens, Powell's, and etiological classifications. Then we saw what are the investigation methods, that is general, radiological and laboratory methods, to narrow down our diagnosis. Then we moved on to anatomical basis and differential diagnosis. Finally, we came to the treatment part. In treatment, we saw two types of treatment, conservative treatment and surgical treatment. Conservative treatments, there were some disadvantages of those methods, so we moved on to surgical treatments. In surgical treatment, we saw two types, that is internal fixation and total hip replacement. Then we saw what were the complications and the post-operative care. So this is the bibliography, that is from where we have taken all the information for this seminar. What is the source of the information? And this is Mrs. Shubhda. Now, I take this opportunity to thank Dr. Yuvraj Bhosle sir and the whole anatomy department for giving us the chance to present this seminar. I also thank our mentor Dr. Vivek Hingmere sir for guiding us through every step of this presentation. I would like to appreciate the hard work of all my team members. I humbly accept that we might have made some mistakes during the presentation of this seminar, but this was our first seminar. I assure you that next time we present, we will be a better side. Thank you so much.
Very nicely presented, and my apologies for missing the first seminar because the inauguration of our auditorium was there. So please do go and see the auditorium. It was compulsory for all the heads to attend, and it's a big event after 2 years because we have been having all the Dean's address there, and somehow these 2-3 batches have missed, and Anna madam, we can think of applying to Dean sir about the 20th February function, whether we can have only thing I didn't understand that how Shubha, when she fell down, Shubha, she was so young, and then by the time treatment was over, she said, "Thank you, fixed." The treatment took too long. She changed into a sari, by then she from Western clothing to Indian clothing. Conservative treatment, yeah. They I think have gone for conservative treatment. Fracture of the neck of femur, it's we are laughing, but it's one of the worst thing that can happen to an old person, because that's what I still tell my grandmother. My grandmother is still there, she's 100 now. I tell her, पडायचं नाही ताई, काही झालं तरी पडायचं नाही, हळू चाल, घाई करू नकोस, because once an old person falls, it's a fracture for sure. And sometimes, it happens. My mother, she had fallen down and she had this fracture. And then we thought that she fell down, so she had fracture. But actually she fell down because she had stroke. So it's not that old people fall only while walking. Sometimes they fall because of some other reason also. And we kept on focusing on this. And then I found some slurring of speech, and then we did the CT and we realized that there was stroke here, because of which, and this fall was secondary to what happened. Lot of challenges are there in this because old person, female, postmenopausal, osteoporosis. Okay, so all what we eat now reflects there. ओके ये जो मैगडी का बर्गर वगैरह खा के अगर गिरता है ना ओल्ड एज, फर्स्ट थिंग तो मैगडी का बर्गर खाते रहेंगे तो ओल्ड एज दिखेगा नहीं आपको, सो यू विल बी स्पेयर्ड फ्रॉम all these messages. But have a healthy diet, good of calcium, good milk, calcium rich diet basically, very 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 important, especially for the females. This is very important, and even for males to have a good calcium rich. Today nowadays, we are seeing, we do bone scan and we see, those people who come for the bone scan, half of them, the bone density is not good. Students of your age also, the bone density is very bad because milk. I think you all belong to that whole group जिसमें मिल्क पीने के लिए नाक बंद करके फिर वो माँ स्कूल में जाने से पहले. How many of you very lovingly have drunk milk? Very few. बाकी सब ये डाल के कॉम्प्लान डाल के ये करके हो. So we should have healthy diet basically to prevent. Healthy diet अगर है आपका तो आप गिरते भी हो तो फ्रैक्चर होने का चांस कम है. ये ऑपरेशन ये वो सब बोलना फिक्सिंग ये इट्स सो इजी. So I actually managed my mother conservatively. Now again, an old person at home, lying on the bed, feeding them on the bed, all passing urine, toilet on the bed. It's so difficult to handle such situations, and every one of us has to do this. We have to be mentally prepared for this, either for our grandparents or for our parents. And I did it for my mother for the last 4 years, 5 years of her life. That taking care completely, at least she had 10 admissions during that time. So what I'm telling is, keeping ourselves healthy, exercising regularly, good food. Junk food, someone say, I'm not against it, कि कुछ भी मत खाओ. Once in a while is okay, but our regular diet should be nutritious. Once in a while you can cheat. Yeah, thank you. Thank you, nice presentation, good slides. Any other staff member wants to say anything? Vivek sir, I'll call Vivek sir to speak a few words because he was the
everybody has taken great efforts. I will like to additionally tell about Chandrakant. Everyone has provided him with the slide, but editing and getting things together is not an easy job. Everyone has done well. Thank you.
Exactly 12 o'clock. एक मिनट. Because this is the first seminar, I would like to add this. All of you must have realized one thing. कितना मिनट था आपका? 3 मिनट था ना सारे का. तो 3 मिनट के लिए आप रात भर कैसे कर रहे थे? हाँ. और यहाँ पे टीचर्स 1-1 घंटे का प्रेजेंटेशन करते. So how much we should appreciate our teachers. I think those who presented, your appreciation for the teachers, and then how everybody should be attentive. Other thing is जो पीछे बैठे हैं, you should take this opportunity to revisit all these things. जैसे फीमर ये वो भी हम लोग को तो बाय हार्ट है, फिर भी हम लोग जितना हो सके from our end we still listen. Because anatomy is a volatile subject. आप जितना नहीं तो otherwise यहाँ पे बैठ के आप अगर टाइम पास कर रहे हो, that's the greatest loss. And this such presentations are so nice. I'm going to upload it with the permission of this thing, so that आपको कभी आप बड़े सर्जन ऑर्थोपेडिक सर्जन बन गए तो फिर आप तभी you can revisit and see how you presented.